Um, as Shripriya was mentioning, we are going to enter into a process of learning, by the end of which all of you would be able to practice palliative care. Okay, in that, our first session is going to be on introduction to pain. For that, we have Dr. Barathi Bakthavatsalu. I warmly welcome you to take us through this session. She is a palliative medicine specialist who has obtained her master's degree in palliative medicine from Cardiff University, UK, after her MBBS. And she's also done her research, like she has obtained a PhD in palliative care too from Lancaster University. So she has both clinical and research experience in both national and international level. And she not only there, she has had a wide experience in the teaching aspect also, as she is one of the national faculty of IEPC and also honorary tutor for MSc program in Cardiff University. And above all, she is also a member of the steering committee of the EAPC research network too. So you've got someone who has wide clinical, teaching, and research experience. Who else can take you through this better? So, and she has also obtained her postgraduate diploma in geriatric medicine, and her main interests are palliative care for non-malignant diseases and symptom management in geriatric. So, which is, nutshell, the crux or the main, one of the main patient group which you will all be seeing. So with that, I hand over it to you, Dr. Barathi Bakthavatsalu, to take us through the session.
Okay. Thank you, Dr. Radha Venkatesan, for that warm introduction and welcome. I'm very happy to be associated with Pallium India and to share my knowledge, whatever I have learned through the years of experience. Okay, so I hope and I want to keep this as an interactive session. So please do come up with questions that you have, and you can stop me in the middle and you can ask me questions and raise your hands in the Zoom. You can put that, that raising hands icon. Yeah, and I think we also have a case presentation today. So I think I would like to combine that in the middle of the teaching, so that we can learn and implement what we have learned from the teaching today. So yeah, I'll share my slides. Okay, so are you able to see my screen?
Yes, we can. Okay. You can make it to slideshow screen if you want to. Yeah. Thank you. It's there up. Ready.
All right. Okay. So today we are going to see about pain. So it's an introductory session to pain. I think there'll be more sessions to learn about the management, I think. So I'll be today giving you an overview of pain. So what is pain and how we can, manage. So we'll be seeing the definition of pain, causes, classification, and then we'll a little bit delve into assessment of pain in detail and management as an overview. So this is what we'll be covering today. So first of all, we are going to learn what is pain. So in simpler terms, so pain means when the patient or a person comes and tells you it hurts. So when somebody says it hurts, it could be physical. It could also be, emotional. So when somebody is hurt, when someone scolded you, So we say, she got me by saying this. So pain itself, it is both physical and emotional. So that's a simpler term. The International Association for the Study of Pain, IASP, defined pain in a more in a comprehensive way. So it defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So I don't know how many of you completely understand this definition. I think if you understand it, it's easier to memorize, because you will be using this definition throughout your your practice and your course. So it's a sensation, it's unpleasant sensation too. So if anyone asks you what is pain, in simpler terms, you can say it's unpleasant sensation. So you feel it, so that's a sensation. And you also experience it emotionally. So it's not just, although it occurs in your body physically, you also feel it as an emotional experience. So remember, pain is always physical and emotional. So that's a simpler definition that you can remember. And these sensation and emotional experience is associated with actual or potential tissue damage. So what is actual, what is potential? So there's a question, right? So actual is what you can see, you're able to visually see and appreciate. For example, there could be a cut, that you can see physically. So that's actual tissue damage. Or it could be potential tissue damage. Potential is where, for example, a blunt injury to the abdomen, okay, where you won't be able to see the damaged cast inside unless you take a CT scan of the abdomen. Okay, so we tell the patient and the family that there could have been tissue damage inside, organs could have been damaged inside, So that's a potential tissue damage. So there's a possibility of damage inside, or described in terms of such damage. So what is this described in terms of such damage? Is, for example, we say, the patient comes with epigastric discomfort. We say it could be because of gastritis. And we say that if you leave it like this, your stomach will get damaged. The upper layer of the stomach will get damaged. So we say that it's going to occur in future. So it may be that it could have been damaged, although we don't visually or technically see at that time. So I don't want to confuse you, but I'm trying to explain you what is this definition means. So just remember, this is an unpleasant sensory and emotional experience. It could be associated with either actual or potential tissue damage. So just remember these 2 points when it comes to the definition of pain. Okay, so any questions? Confused or is it clear? Okay, so I think all of them are clear. Okay, right. So move on to the causes of pain. Okay, so here we are going to see causes of cancer pain in particular. So because in palliative care, we'll be very often treating cancer pain. So the causes of cancer pain, that's what we are going to see. So pain could be caused by a direct effect of the tumor. So for example, a tumor invasion or a compression, or because of its treatments. For example, radiation, probably it could have caused radiation proctitis. So patient could have pain in the lower abdomen and diarrhea and so on. Or it could also be due to indirect effect of the disease, such as pressure source from immobility. So if patient is bedridden for a long time because of say spinal cord compression caused by a tumor. So pressure sore can occur because of the immobility. Or it could be a disorder which is totally unrelated to the primary disease. That is, it can be totally unrelated to cancer, such as osteoarthritis. So they could be co-presenting other diseases which could cause pain. So most commonly patients have cancer-related pain. So cancer has a direct pain. So 76% of the patients have pain related to cancer. So it is really huge number. So I think we need to, put our effort to learn and diagnose how cancer could cause pain and what are all the mechanisms which could cause pain in cancer patients. And 11% can have pain related to its treatment, and 5% have pain due to indirect effect, and others due to unrelated conditions. So remember why I put this, the survey result is, when we say pain, we forget the big picture. We always see only cancer. That's what comes in front of our eyes. We forget, when patients say pain, there could be also pain related to other conditions. So if we don't look into these issues, we are not treating pain as a whole. So that's why we need to remember what are the possible causes of cancer pain. All right, so classification. So how can we classify pain? Pain in a more comprehensive way. So this is hand-drawn picture of classification. There are many classifications, very comprehensive, very complicated things, but I just want to keep this as simple. So there are two kinds of pain. So one is which is related to temporal factors, that is the time length of the pain. So we can classify that as acute and chronic. And another is related to the damage that occurred to the tissue and non-neural tissue. So which could be classified as nociceptive and neuropathic. So acute, when we say acute pain caused by, usually by an injury, okay, which is, which occurs in less than 24 hours of time. So it's very immediate. So that's what acute pain. Chronic pain is lasting for anything which is lasting for 6 months or more. So that is chronic pain. Nociceptive pain is again divided into, we'll be seeing a nociceptive and neuropathic pain a little bit in detail a little bit later. So nociceptive pain is usually occurs because of the tissue damage. This is classified again into somatic and visceral. So somatic pain is very common in 71% of the patient, and visceral pain occurs in 34% of the patient. So this percentage is just to tell you an idea about what kind of pain is very common, so that you are aware when you are treating pain. And neuropathic pain is divided into peripheral and central, depending on the nerve tissue damage it causes. So if there's a damage to the peripheral nervous system, it's called peripheral neuropathic pain. And if it is damage or lesion occurs in central nervous system, we call it as central neuropathic pain. So from this slide, I want you to remember pain could be classified as acute and chronic depending on the length of the pain. And depending on the cause of pain, we divide them into a major type of pain, which is nociceptive and neuropathic. So nociceptive pain. So what is nociceptive pain? IASP gives a definition for this. So the pain arises from actual or threatened damage to non-neural tissues due to the activation of nociceptors. So it's very clearly mentioned that we saw in the definition tissue damage, right? So here they are more specific in saying non-neural tissue damage. So pain arises because of non-neural tissue damage. And it involves the activation of nociceptors. Nociceptors are those, these are all receptors which involved in the pain signaling pathway. I think you will be learning this in pathophysiology of pain. So there are different kinds of receptors involved in pain signaling pathway. So nociceptive pain, as we saw, it's classified as somatic and visceral. And somatic pain, the quality could be throbbing. So when you ask the patient, I don't know, in English, it's very hard to describe. So it differs in language. So you need to learn those terms in your local language. So what you would say for throbbing, it's very important. If you have not used those terms, you try to learn it in your language and learn how to address that to the patient, how to ask these terms to the patient. So it could be throbbing, it could be sharp or an ache, and it could be, most of the time, it is localized pain. So what is localized means? Patient will be able to pinpoint where the pain exactly occurs. So if there is a cut injury, the patient could say that, it's exactly over this area, a little bit around that area where the tissue is cut. So it's a very characteristic of nociceptive pain. Okay, so what is neuropathic pain? So there's a subgroup of IASP, neuropathic pain special interest group. Okay, so they work only on neuropathic pain. So this group defined neuropathic pain as pain caused by lesion or disease of the somatosensory nervous system. So what is the somatosensory nervous system? It's a system of nerves which involves in carrying the signals which occurs in the body, that is soma. So it could be pressure, or it could be a change of temperature. So this network of nerves carry these signals to the brain and bring the feedback to the body, how to react to that pain. So to withdraw the limb, or show, express it through facial expression. So this is what neuropathic pain. So it could occur because of the lesion or disease of the somatosensory nervous system. So there's an involvement of somatosensory nervous system in neuropathic pain. Whereas in nociceptive pain, there is an involvement of nociceptors. So that's what it differentiates. So as you learn, you try to compare and contrast so that you remember very clearly what kind of pain is this. So this pain is described most of the time as numbness or burning or a sharp pain, or it could be shooting pain. Suddenly it's kind of like shooting pain is like shock-like pain. It's like, sometimes it could radiate from one place to another. Or it could be nagging pain. So this kind of nagging pain is very difficult to describe, but I have seen patients try to tell me about that pain, but it's a very vague pain that they cannot say. Most of the time they say there is a discomfort there. I feel it is not normal. My skin is not normal in that area. So there's this, it's a nagging type of pain. And it could occur either on movement or suddenly, spontaneously it can occur without any trigger, unlike nociceptive pain. So suddenly it can occur, and we cannot predict how long it's going to last and whether it's going to be severe. So it's very unpredictable pain. And nocturnal pain is classic of neuropathic pain. So when patients say this pain comes only in the night time or in the early morning, then you have to think of neuropathic pain. So these characters you will have to remember when you take the history, pain history. And we already saw neuropathic pain is divided into peripheral and central, depending on the site of damage it is caused. Okay, visceral pain. Visceral pain is most of the time it's nociceptive pain, but it's a different category from somatic pain. If it occurs due to the obstruction of hollow viscera, such as intestine or ureter, patient describe this as a colicky pain. Okay. Otherwise, the pain is very vague. Maybe in gastritis, patient may be able to say it's burning. Otherwise, most of the visceral pain are very vague pain, and this term gnawing is not well described in Indian patients actually. So they either say it's some kind of pain which they're not able to describe, or it could be colicky pain. And characteristic of visceral pain is that it's a referred pain. Patient may have referred pain. For example, in gastritis and cholelithiasis, pain is referred to the tip of the shoulder. And similarly, for patients with ureteric pain, it radiates to the pelvis and often to the inguinal area. So this referred pain is again classic of visceral pain. So when you know which viscera can radiate pain to which part of the body, then it's very easy to diagnose visceral pain. All right, so we saw definition of pain and classification. And now we move to an important part of the pain assessment. So how do we assess pain? And why should we assess pain? If someone comes and tells you pain, why don't you just give some medicine? We can't just give NSAID to everybody. We can't just give tramadol to everybody. We need to assess in order to manage them in the right way. That is why history taking is very, very important. So when you take pain history, we usually ask, as we learned in the basics in medicine, how in history taking, where, when, and what, and all that. But there are certain acronyms are helpful in taking pain history. So one is P, left side. P stands for provocative and palliating factors. So provocative and palliating factors are, provocative is which triggers pain, whether it is movement of the limb or a position. So you ask them what is provoke the pain. Palliating factors, what are the things that relieve pain or comfort pain or reduce pain? For example, it could be resting the limb, or it could be just pouring water in that area. If it's neuropathic pain, burning pain, patient may say that putting my hand in cold water feels good. So that gives you a clue. So ask them provocative and palliating factors. That stands for P. And quality of pain, as we just saw, there are nociceptive pain has got different characters, and neuropathic pain's got different characters. So numbness or burning or shooting, what kind of pain? That's a quality of pain. Radiation, whether it radiates from one place to another place. And S stands for severity. So how severe it is. So we'll be seeing some pain scales to assess the severity. So whether it is like severe, mild, moderate, severe. So how intense the pain is. And temporal factors related to time. Does it occur particularly at night or or any time of the day? Does cold or hot things aggravate pain? So these are related to temporal factors. There's another acronym, Socrates, for pain assessment. More or less, it's the same. So you can choose what you want to adopt to your practice. So it is site. S stands for site. O for onset. The onset, as we saw in neuropathic pain, it starts spontaneously, that is suddenly. Whereas nociceptive pain, it starts slowly, in the sense mild and intense, and then it becomes severe. So that is onset of pain. And character of pain, radiation, associated factors, means does it associate with the movement of the limb or in any particular position, and timing of pain, exacerbating and relieving factors, and severity. So you can choose one of these acronyms to take the pain history so that you don't forget to ask any of the details. So there are certain terms I just want to bring the attention to. So these things may be described by patient, but you do not know unless this is a type of pain. Okay. So allodynia, so patient may say that, even if somebody touches in that area, I have pain. So painful response to a non-painful stimulus is called allodynia. So that means patient is having allodynic pain. This could occur in neuropathic pain. And hyperalgesia. Hyperalgesia, this is, okay, you touch that area or, prick it with a pin, which usually causes mild pain. But patient with hyperalgesia may have exaggerated painful response. So you just have a small prick and they just withdraw the limb. So exaggerated painful response to a painful stimulus. So that is hyperalgesia. Again, most of the time it occurs in neuropathic pain. And breakthrough pain itself is it's a type of pain. You will be learning that in detail in other classes and forthcoming classes. So this pain, this can occur in varying intensity on a background pain. Say, for example, in fracture humerus, patient may have, you ask him anytime that, okay, I have pain, say 5 out of 10 in the numerical scale, which is controlled with NSAID and paracetamol. But suddenly, the pain may go up to 8 or 9. So that's called breakthrough pain. A sudden pain of varying intensity occurs and a background pain. So this is called breakthrough pain. So when patient may come and tell you these things, or if when you are taking the history, if you find that this patient has got neuropathic pain, you have to explore further whether the patient has got allodynia or hyperalgesia, or a breakthrough pain in case of nociceptive pain, because breakthrough pain management is different from the pain management that we are usually do in the routine practice. Right, so we talked about assessing severity of pain. There are pain scales to help assess the severity. This one is called visual analog scale, VAS. And so it's called as VAS commonly among the pain practitioners. So what is this VAS is, you have a scale from 0 to 10 centimeters. 0 is no pain and 10 is extreme pain. And you ask the patient to mark with their hand where how much pain they've got. So if they put a mark in the quarter of in the scale, that means patient has got mild pain. If they mark it more than 3/4, that means patient has got severe pain. So this is visual analog scale, where patient can see the scale visually and able to grade it. What is shown on the right side is you can see there are two things. So one is categorical numerical scale. That is, the scale could range either from 0 to 5 or 0 to 10. And 0 to 5 is, moderate pain. From 5 onwards, it is moderate. And more than 5, anything more than 5 or 7, it is severe pain. The same categorical scale could be asked verbally. So if patients who do not understand numbers, you can ask them, is it little or more or, very bad? So if patient tells you it is mild, it's mild pain. So that is categorical verbal scale. This scale also could be combined with phases for pediatric patients. So for children, they don't know, to express it in numbers very clearly. So the phase is represented alongside the grade of pain. So if it's a happy phase, there is no pain. If it's a little bit, the smile is a little smaller, that means the patient has got mild pain. If it's a grim, then means the pain is, really, getting worse. So you can, from the face, you can, relate that to categorical scale and then assess the pain. Any questions here? Most of the time, what we do is we confuse VAS, visual analog scale, with categorical numerical scale. So in VAS scale, there are no numbers given. It just graded from 0 to 10. And we ask the patient to mark in the scale how much pain they have. So 0 is, tell them that 0 is no pain and 10 is severe pain. So they have to mark how much pain they are feeling. So they that is visual analog scale. And numerical scale, you already have the numbers marked in there. So patient has to just circle the number. So that is numerical. Verbal, you ask them mild, moderate, or severe. And this phases scale is alongside with the categorical numerical scale. Phases scale is used for most of the time to an illiterate or a pediatric population. So this will tell you the severity of pain, how much pain the patient has got. And we've got, apart from this numbers alone is not enough, because we are going to see in a couple of minutes that pain is not just physical, right? So from the definition itself, we saw it is an unpleasant sensation involving an emotional aspect of it. So there are comprehensive pain scales have come up to address the emotional, social and spiritual part of the pain. So brief pain inventory is a very comprehensive scale that covers all aspects of pain. And McGill pain questionnaire and neuropathic pain scales like pain detect DN4, they are specifically designed for diagnosing neuropathic pain. So I think you will be learning as you learn about the pain management in detail. So I'm just giving you an overview of what are the pain scales available here. So after taking the history, we have to examine the patient, right? That is how we diagnose a condition in a patient who comes to us. So in physical examination, you need to inspect the part where the pain arises. So local examination is very important. So inspection, palpation, definitely look for swelling or inflammation, redness, increased vascularity. Okay, and you look for warmth. If it's nociceptive pain, if there is a tissue damage, you can feel that place is warm. And so mobility of the limb may be decreased. There is a damage to a limb, and power of the limbs may be reduced or compromised. And you should also check for reflexes, both sensory and motor. So just because patient says pain and you are able to visually see the injury, you should not neglect examination. For example, in patients with nociceptive pain, so a patient comes to you with a cut injury, you may feel the pain is extending. For example, if there is an injury at the forearm, patient may have pain, even up to the elbow. If within 48 hours of injury, what happens is like there is a hyperalgesia surrounding that cut injury. So you will be able to, if the patient is not conscious or not able to express, you will be able to determine the time of injury so that you can treat the patient. So never forget to examine the part where it is involved. So as I just told you, remember always this is pain involves all aspects of a human being. So it's psychological, social, and spiritual. So when you take the history, also when you have a chat with a patient, look for these things. So physically, we have learned a lot now. So what to look for, physically. So the picture on the right side what could possibly cause pain in other aspects. I'm angry, okay. It could cause pain. For example, anger because of the treatment was delayed or diagnosis was delayed, or it could be disfigurement. Patients with head and neck cancer have this kind of fear, embarrassment, of disfigurement. So that could cause pain. And
Yes, ma'am. I was trying to Dr. Bharati.
Yes.
Actually, we are losing you.
Hello.
Yes, ma'am. Actually, we lost you a lot in between. The audio was very much fluctuating. So initially, I was thinking it was on my part, but maybe a couple of last few sentences we lost, I think.
Okay. So now is it clear?
No, ma'am. We can't say that it is crystal clear. Maybe you can just try switching off your video.
Check my internet connections. Yeah, I'll do that. Is it better?
Yes, much better.
Okay. All right.
You'll have to start sorry to interrupt. You went about with physical and you were mentioning about disfigurement. From that time onwards, it started, your voice started breaking, please. Looks like we are again lost.
Yeah, I'll start. Okay, just give me a minute.
Please repeat the last 2 or 3 slides. I think the last 2.
Okay, so can I start with this slide, physical examination, or they go back one more slide?
It was Chidananda. Is that okay if we start here, please?
This should be fine, madam.
Yes. Please go ahead, Dr. Bharati.
Okay, thank you. So after taking the history, physical examination is very important, as we get a lot of clue by examining the local area of redness, palpate for warmth, and also elicit hyperalgesia, both in case of neuropathic pain And in case of nociceptive pain, hyperalgesia could be there for the first 48 hours. Look for increased vascularity due to inflammation, or compromised power of the limbs. The limbs are involved. This is particularly important if you are examining a patient with spinal cord compression. And also look for deep reflexes, both sensory and motor. So it's very important, that we need to examine the patient. Most of the clinicians tend to write the prescription after they assess the pain intensity. But I think that's not, encouraged. You need to look at the part where it is damaged, and even if it's your sensory and okay. So moving on to the next slide. So as I said, pain is total, it involves well and social. So we have learned a lot about physical pain, how to, what is the cause of pain, etc., etc. But patient can
Dr.
also
Bharati, sorry to interrupt.
have psychological.
Dr. Bharati?
Your voice is getting broken a lot, Dr. Bharati.
Problem with the internet.
Way of identifying the intensity, and the other one is like if a patient is unable to speak, like dementia or something, what is that they would use to measure the pain? Those were the two things there in the chat box.
Okay,
Thank you, Dr. Bharati.
What was the first question? I'm sorry.
First one is to find intensity. The message in the chat is to find intensity of pain. I was thinking about to ask them, do they want to find out how to know the intensity of pain? Bhargav Dev has asked. And then Dr. Yeri, what is the scale used to assess for a patient who is not responding or delirious?
Okay, I think for the first question, we have already answered, I think, through the PowerPoints. So, right? And the second question, if patient has dementia or cognitively not able to, respond, so you need to pick up with the facial clues. There are, when you learn pathophysiology of pain in detail, you will be learning what are all the responses or reactions, to pain in a patient. So, for example, if there is a patient who's not able to express anything, so how will you assess pain? So, one is a very important thing is facial expression. And when you touch the area of pain, patient, move the limb, or try to withdraw the limb. Okay, and third one is you assess the nerve involvement in that, if to find out whether it's a neuropathic pain. So, in patients who are bedridden, who are who's got cognitive deficiency, or patients who are in coma, generally used pain scale is facial expression. So patients got grim, and they may try to keep the eyelids very tightly closed. So these will give us the clue that patient is in pain. And in them, pain management is totally different, in the sense like you cannot just go on increasing the pain. You need to very carefully titrate pain medication in those patients. I hope this answered the question.
If you don't mind, Dr. Bharati, I am also a chronic pain physician. I can
Okay.
add on few if it is
Please
okay
do.
with.
Please do.
Okay. So like I'm going to give you examples. I'm an anesthetist, intensivist, and a chronic pain physician. So some things what all of you know, like see in intensive care, like patient is intubated, ventilated, nothing. So tears, all what she said is 100% true. I'm just going to add on few points only. One is sometimes tears. And then next thing is that vital parameters also will help you. Like the pulse rate, blood pressure, everything. So like, for example, the arterial trace, everything, every parameter that you see will also be of help to you. Mainly facial thing is that grimace or squeezing their eyes, and then they may squeeze the hand. We even tell them if the patient can't speak, if the patient is intubated, we'll tell, if it hurts, squeeze my hand. So that is one thing. They can withdraw, and next is your tears may be there, vital parameters. All these are additional factors. And for dementia patients and all, there are separate tools also for that. You have separate tools for specific diseases also. There are multiple pain tools available, specific for each particular type of disease also is there. Okay. Thank you, Dr. Bharati.
Thanks, Dr. Radha,
Please go
for
ahead.
adding that. Yeah.
Can I please intervene? Can I just add something to it? I'm Dr. Shikha from Dhyanand Medical College and Hospital, Ludhiana.
Sure.
Actually, we are using CNPI score. It has 6 points. Like for these patients who are in delirium or who are in dementia. So the first score one is like vocal complaints, non-verbal means sighs, groans, cries, or facial grimaces are there. That is the second score. Third is bracing. Bracing means clutching, or the patient holds on to furniture or equipment, or some sort of movement is there in the patient. Fourth is restlessness. Fifth is rubbing. Rubbing means massaging that area of pain. And sixth is patient says ooch, or he says stop. Some verbal sound. So 6 points are given to the patient, and even if patient has point, means if his score is even 1, so the physician has to intervene for the pain. This is actually what is recommended, what we are following in our hospital.
Okay. Can you just put that in the chat box so that everybody?
Yes, ma'am. I've already written. I answered
Okay.
Dr. Shreya. We use non-verbal scale CNPI.
Okay.
It is knowledge. It is. I will write the details if it is required. I can write the details to the same.
Okay.
The 6 points what you mentioned, no? So that is very good. So all what we have said, you've compiled everything into that. So just put those 6 points, which will be good, I think. That should be. Okay. Thank you very much. That's how one tailor-make we say. Each place or each institution will have something pertaining to your area. And as Dr. Bharati said, specifically with neuropathy, each regional place has their, like local people will have one particular way of mentioning it. And for that matter, all languages have that. So each one has to know what is that particular, see, because it will not be something related to pain. There will not be any word of pain in that at all. Normally, as she said, it may be said as, oh, I cannot explain, or I cannot put it in words. But regional wise, each language has something. See, for example, I'll tell you, if I am basically from Tamil Nadu, so Kodachal, which is nowhere related to pain. And in Malayalam, they say as Tharipu. So it's all different word will be used. But it is a form of discomfort they are expressing. So regional and what pertains or what works for your particular area, that something, all these pain tools, what we are giving you, you have to combine and tailor make what suits your patient.
Exactly. Thank you, Dr. Radha and Shiksha for adding those details. I'm not able to see the chat box. If there is anything, please let me know.
I'm keeping track of the chat box. You go ahead, Dr. Bharti. I'll keep you
Okay.
updated.
Okay, thank you. All right, so we were talking about psychological pain. So there was a patient with cervical cancer, complained of low backache and lower abdominal pain. She was on radiation. She was on stage 2A, I think, cancer cervix. So we related the pain to her cancer and probably radiation. So we started her on step one, that is, we gave her NSAID. The pain was not controlled, and we stepped up the ladder to weak opioids, tramadol. We gave 3 times and then 4 times plus SOS, and the pain seemed to be increasing. And the day I went, she was like, crying in pain, and staff nurse told me that she keeps shouting. So we were thinking whether to start with morphine for her. But then I thought I should have a chat with her, so I sent everyone away, and then I sat with her and asked her, so what is it and what's causing pain, or how does she feels, when there is pain and all. And then she started, she telling me totally a different story. She said, pain is not a problem at all. And I was so shocked. I said, what? So what's bothering you? And he said, there's something else that's in the family and which keeps disturbing her. That whenever she think about that particular problem, she feels there is pain in the abdomen and back. So I asked her, and what is the thing? And so I went into the thing, and then I referred her to the counselor, and we gave her a dose of sleeping pill at the night. She became all right. Next day morning, she did not take tramadol at all. She was able to sleep without any pain medication. So she said the talking was helpful, and she feels better, and she was able to continue the radiation treatment and did not require any opioid at all. She managed with only with SOS and SAD. So what I was going to tell you here is psychological component definitely play a role. So that the pain which is mild may be exaggerated by what is going on in their mind. So if we don't address emotional issue at the right time, we may tend to mistreat pain. So I was about to treat morphine, but in a day's time, she came down with pain came down with NSAIDs. So it's very important that, as shown in the picture on the right side, is there any pain? Is there any fear of pain or fear of death? Feeling of helplessness. So those issues we need to explore. And also social issues. So if patient is a breadwinner, losing their job, could jeopard the family's finance. So, and loss of social image, loss of role in the family as well as in the society. This could cause, could aggravate or potentially, can increase the pain. And spiritually, we all know that, if we go through problem, we always blame God, right? So why this happened to me? Is there a God? And so those kind of spiritual issues also needs to be addressed. So apart from taking pain history and assessing pain, and we should have a dedicated time to explore the psychological, social, and spiritual issues, which is very, very helpful to treat pain effectively. So don't forget that pain is, involves all aspects, and we have to treat total pain, not just physical pain. Okay, so in the next slide. Hello, are you able to hear me?
Yes, ma'am, you're audible.
Okay, all right. So So this picture shows a holistic approach to pain treatment. So whatever we have seen earlier, this is what this picture summarizes. So look for, as for the description, using one of those acronyms or whatever that you're familiarized with yourself in taking the history of pain. And cause of pain. Never forget there is pain related to non-cancer issues, which could, aggravate the pain, or it could contribute to more pain. And as we just saw, non-physical factors, physical, psychological, social, don't forget to explore them. And always remember the mechanism of pain, which is very important to treat pain. So is it nociceptive or neuropathic? Or is it just functional? Is it even a muscle cramp, could be troublesome at nights. So just remember this pain, needs a comprehensive assessment and a holistic approach. Okay, so can I stop here and ask, I think Dr. Kavita, right, for the case presentation?
Yes, we can do, Dr. Bharti. We can do the case presentation straight away.
Okay, so I thought if she could present the case now, we can learn the assessment and history, and then we can move on to the management later.
Yes. As you mentioned, like we have 3 sessions for pain and 1 more session for methadone separately. Pain is dealt in detail because generally we say palliative care, 80% is covered by pain and breathlessness. So we have 3 sessions for pain and 1 session for methadone separately. So, so we'll go ahead with the case presentation and then can have a discussion together also.
Okay.
Thank you very much. We'll they can, Shripriya, they can go ahead with the case presentation. You've already got the slide. Thank you.
Kavita, it is okay.
Yeah, do I present?
Yes, you can.
Okay. Yeah, thank you. Good evening, everybody. So, we had encountered this patient. It's a male 88-year-old elderly patient. His son had actually contacted us. They actually discovered that he was suffering from liver cancer and involving 70% of the liver. And the diagnosis was already made before they came to us. And, the diagnosis with liver cancer with spread to the cervical spine, lungs. This was a diagnosis. And he was also a long-standing diabetic, hypertensive, and with BPH. So they directly came to us saying that, we have come here for palliative care. They have refused all hospital-based care, all sorts of aggressive care, and not even investigations, further biopsy, or any sort of investigations. So this is a general view of the case. Next slide. And they noticed, they came with a presenting complaint that since in the span of 2 weeks, he started showing faster decline in his general condition. His oral intake reduced, his communication with family members dropped, mobility reduced, and he also started becoming more restless and agitated. All these happened in just a span of 2 weeks. So not much of time was required for this decline. So this was their main complaint. Yeah, next slide. Okay, this is the same thing which I had, the same history which they had come up with. One very interesting here is family, the second paragraph, family was not willing even for biopsy, as it could be extremely painful for the patient. So they were very particular that they didn't want any sort of pain to happen to their father. And hence they have also denied the surgery, chemo, radiations, everything was denied by the family, and they wanted a peaceful passing of this patient at home with some symptom management. Yeah, that's it. Next slide. Yeah, examination, his on presentation, his vitals were stable. He was hemodynamically stable. Pain score was somewhere between 4 to 5. But he seemed restless. He seemed agitated. He was not able to communicate exactly where is the pain and all that. But looking at him, we realized there's something going on, some discomfort he is facing. Lungs were clear, cardiac no murmurs, abdomen, nothing palpable we could find. There was no distension, bowel sounds were absolutely fine. Maybe we could speak, actually, with 2-finger breath, we could palpate his liver, which was not tender. From the CNS point of view, no major focal neurological deficit we could make out, except for higher cortical functions, presentations like restless, agitated, poor response for oral questions. Yeah, next slide. Now, this is how we started. Since he was restless and agitated, we thought that first quetiapine might help him. So we started him on quetiapine, 25 milligram. Initial first 2 days actually, did not stop his restlessness and agitation, but it had reduced. The intensity of those discomfort had reduced. We had to increase it to 50 milligram. Then even with 50, it continued. So we had to put him on tramadol sustained release. After a few days, we also had to give him lorazepam. These were his other medicines for his low sodium, for his prostate. He was taking Veltam and sodium supplements. He was also on Neurobion Fort. Then during the course of this care, the son noticed some reddish color on his tongue in his oral cavity. It looked like bleeding. There was some clots in his mouth with bleeds. But the patient was conscious. So then we realized maybe he could have had an upper GI bleed, which has actually come out there. There was no suctioning, no oral trauma, nothing was a precipitative cause. And we started him on pause, 500 mg, and with antacids. This actually took care of his bleeding. The bleeding had stopped. The next day, there was no blood clots in his mouth. We also planned to give him some vitamin K supplements. Dufalac was for his constipation. He was and his antihypertensive oral hypoglycemic agents were withdrawn because the oral intake was itself very poor, and he was dropping towards a low blood pressure and low blood sugars. This patient was at home. We were managing him at home. He didn't want to go to hospital. We never asked for any aggressive investigation because it was already a decided part by the family for not getting into any sort of aggressive investigations. Next slide. Yeah, psychosocial aspect. These were the things. The patient, was very less communicative verbally. He was restless. He was agitated. When he was asked to sit or asked anything, he used to say, just give only one monosyllabus answer, yes, no. Seemed like he was in some sort of mild, constant pain. Family was fearful of patient suffering from any pain, discomfort. They didn't want to cause him any pain or discomfort until the end. They didn't want any sort of tubes also to be inserted into him for any support. So no tubes were inserted without their consent. Yeah, next slide. Medications, this I've already discussed in the previous slide. Later, in the later stages of his life, the son came up to us, doctor, he, in spite of all these things, seems like he's still, sometimes in the night, he seems to be in discomfort, but he's not able to localize where is the pain. There's some agitation, some restlessness is still persisting. And he was in discomfort. So then we decided to start him on fentanyl patches, which we tried to procure it from a nearby hospital, and the same was administered. Yeah, next slide. So here the main concern was pain relief, no discomfort. grave prognosis was already known to the family. Next slide. Okay, this is the same entire summary. Actually, the family got to know about the cancer when patient complained of a pain in the arm. First, it was a pain in the arm which persisted. Then this resulted in getting an MRI. MRI neck revealed that there was a mass near the neck area, and then additional whole body MRI then revealed that there was an advanced stage of cancer, that actually metastasized to his lungs and spine. It was so far advanced that a biopsy to determine the origin of the cancer was deemed unnecessary. So since it was already a widespread of this deadly disease, family concluded that they did not want any intervention on him, also in view of his elderly age. So the entire mission from the family and from the medical team was to keep him as comfortable and as pain-free as possible. Yeah, next slide. So now this patient actually, he after fentanyl patches, he was actually drowsy. Looked like then after 2 days he passed away. And the family felt that that finally he passed away without any pain. So what I wanted to understand is the pain management, the pain medications which we had given. Was it, were we going on a right direction? And the emergencies which we handled, like the bleeding in the oral cavity for his restlessness in the middle of the night, how do we handle those emergencies? And availability of opioid medications was a little tough. Here actually we only get, I'm from Bangalore, and we could get it only from the onco centers like Nimans, where we had to write a letter to the HOD of the onco center and then get it from them, and that had a lot of time delay, more than 24 hours to procure that by the patient party, go to the onco center and get it. So if we could directly prescribe in the pharmacy, but somebody could give it looking at a prescription, it would have saved some time in procuring the medications. So that's it.
Okay, thank you, Dr. Kavita, for the presentation.
Thank you.
And
Yes,
so
thank you, Kavita. Nice bringing up a case, like something where all things you brought. I'll wait for Dr. Bharti, and then your each concern has one. We have one session in. If you go through your number of sessions, each concern, there is a session you will have for all of them. So
yeah.
Dr. Bharti, you go ahead, and Dr. Chidananda has raised his hand.
Yeah,
You
yes,
could
madam.
unmute and ask, please.
Yeah, this thing was, Dr. Kavita presented a nice, interesting case. Only thing is, my thing was, what I felt was, since the patient was conscious, is able to comprehend, communicate, like all this decision was what Madam told. What I could understand was the decision was from the family members, like to put a ceiling of care, no more investigations. Only it was more like a comfort care what was being planned. Okay, was the patient also involved in this treatment planning? That's what I felt was lacking. I don't know.
Okay, here the patient was not comprehended. His cognition was not up to the mark.
Okay. That's not, because see, thing is, sometimes when the patient is able to comprehend, maybe elderly gentleman, maybe quite advanced disease process, but if the thing is involving them in the decision process also, I think takes care of a lot of this psychological symptoms.
True. Here we could not answer patient because he could not take decision. Maybe it would have spread to the brain also, but because they didn't want any investigations further to put him into the trauma.
No, that is fine. That is fine. What we are looking at is comfort care. Whether the patient also could have been part of the decision making. That's what I
could have. If he was in his full cognition, maybe we could have asked his opinion too.
Yeah, thank you, madam.
Thank you.
Okay. All right, so that's a very good case presentation, Dr. Kavita. So here I would like to bring your attention to pain management. So we'll take it from there. I think in this particular patient who's not able to express anything or not be able to involve in the management. So I hope the patient was able to speak, right, Ravita? Okay, assume that patient is able to speak. So how do we assess the severity of pain in this particular patient? This is what we need to concentrate. So I think as described in the case presentation, patient had complained of pain on the arm, on the right arm. So in the history taking, so we need to concentrate on asking the quality of pain, whether the pain, onset of pain, where does it start, whether it radiates, and intensity of pain, whether there is the pain increases at night. So these would have given the clue that whether this is a neuropathic pain or a combination of nociceptive and neuropathic pain. From the case presentation, we are not able to derive much, details of assessment. But when a patient comes to you like this, this is what you should do. So take a complete history and then assess, and then severity of pain using one of the pain scales that I showed in the presentation. So I think the patient was started on tramadol. So I assume the pain was a moderate pain. So it was a sustained release tramadol, and I think pain went on further, like it was increased. So assessing pain at intervals is very, very important. What happens is in neuropathic pain, sometimes the pain goes up and then it comes to the previous level. Or it could become, go on progressively more and more. So in this particular patient with a C7, C8 spinal cord involvement, I think in addition to adding the strong OPR, we could have also tried corticosteroid. You will be learning about the adjuvant and spinal cord compression. I think it comes in emergencies, palliative care emergencies. You will be learning all of that. But what we need to concentrate here is how to approach this kind of patient, and how do we diagnose pain in this particular patient. So I assume that this patient probably had a combination of nociceptive and neuropathic pain. Probably could have benefited from steroid as well, if assuming that there was a cord compression. Remember your acronym and use one of the pain scale, and do the assessment at regular intervals so that we can manage the pain effectively. Right. So I'm just going to go through pain management very quickly, and then right. So management of pain. So we use both pharmacological and non-pharmacological agents. So pharmacological management of pain is mainly is this using WHO step-ladder approach to pain. So this step-ladder approach has got 3 steps. Depending on the severity of pain, we will be using that particular drugs in that step. So step 1 is for mild pain. And in step 1, we use paracetamol plus NSAIDs. So it could be ibuprofen or ketorolac or anything, any of the NSAIDs. So NSAIDs also you'll be learning in pain management, the availability, side effects, and renal function. All that needs to be assessed, if you start patient on NSAID for a longer term. And for step 2, if patient has got moderate pain, so you carry on with step 1. So step 1 drugs, helps in relieving the pain through synergistic action. So And along with step 1, you can use weak opioids such as tramadol. So there are most common used weak opioids are tramadol and codeine here in India. So codeine is available both as tablets and syrup, and tramadol, I think it's injection and tablets. It's available as both. And you can also use plus or minus adjuvants. So adjuvants are drugs which potentiate the pain relief through acting through other pain mechanism, or it will have its own way of action. For example, steroid is an adjuvant which will reduce the inflammation. By reducing the inflammation, it relieves pain. So these are all called adjuvants. So step 2, we have to use step 1 plus one of the weak opioid plus or minus adjuvants. And in step 3, where patient has got severe pain, so there you need to use strong opioid along with step 1 drug. So strong opioids, the commonly used strong opioid is morphine and fentanyl. Fentanyl is also commonly available, but it is very expensive. So we use most of the time morphine in different forms. It's available as tablet, injection, and also liquid. I think that Kavita was asking about availability of opioid in Bangalore. I think Kidwai Memorial Hospital has got oral morphine as liquid. So you can send a letter, with the diagnosis. I think they'll be able to help you. And for poor patients, this is very helpful. And plus or minus adjuvants. So this is what step 3. So depending on the severity of pain, you decide which step to use. And things to remember when you use the step ladder approaches, when there is an inadequate pain relief, you need to step up the ladder. Means if step 1 drug does not relieve the pain, then you have to go up to the ladder, okay? Not play within the ladder. For example, you have started a patient with paracetamol and one of the NSAID, and patient does not have pain relief. You should not try to change the NSAID from ibuprofen so to some other ketorolac or something like that. You try to step up the ladder, go to step 2 and start on adding a weak opioid. Another thing to remember is when you use strong opioid, I just want to emphasize this point. We always, as I just said, morphine is very, it's affordable and you can easily titrate. With fentanyl, it's difficult to titrate because of the long duration of action, and it is available as patch, which acts for about 72 hours, and titration is going to be difficult. Plus, fentanyl is very expensive. So just remember this. And fentanyl is much potent than morphine. So you can, in that particular step, you can play within the ladder, within that step, but not in other steps. So you can change from morphine to fentanyl because fentanyl is more potent than morphine. And also there's something called opioid rotation that you will be learning much in your pain management in detail. So where pain is not responded to, one of the strong opioid, we tend to change to another strong opioid in order to activate other pain pathways. For example, opioid, commonly used drug for opioid rotation is methadone. I think Dr. Radha mentioned that you will be having a separate session for methadone here. So these are all the things to remember when you use a step ladder approach. There are side effects to remember. Whenever you give a drug, you need to know their side effects. So most common side effects are gastrointestinal, so nausea, vomiting, constipation, and autonomic side effects are there. So remember that particularly if you have a patient, a geriatric patient with you, you need to remember these side effects: postural hypotension, urinary retention. It can cause xerostomia, and most of the people have drowsiness in a couple of days after you start them on strong opioid, and usually that weans off. But there are severe adverse effects or respiratory depression, delirium, myoclonus, and seizures. So if these things develop, you need to immediately stop the strong opioid and try to treat the side effects. Okay, adjuvants, as I said, these are all agents which they help, treat pain through other mechanisms, through potentiation of the pain pathways. Pharmacology, there are pharmacological adjuvants and non-pharmacological adjuvants. So pharmacological agents are anticonvulsants for neuropathic pain. And steroid is one of the most commonly used adjuvant, and antidepressants for neuropathic pain. That's also a commonly used adjuvant. And non-pharmacologically, we use TENS, physiotherapy, ultrasound for the pain. So if you have localized pain, swelling, and or muscle stiffness, these can help out. So use appropriate adjuvant along with the pain medications. That really helps. So this is again, this table shows an example of how adjuvants are used in different situations. These pictures, you can find it in Robert Tycra's textbook on palliative care. So you can see corticosteroid indicated in nerve compression, spinal cord compression, and mechanism of action of steroid is it reduces the peritumor edema. So you see how much is given: prednisolone, dexamethasone, and also the side effect is given. It's a very comprehensive table, and you can have a look at it. I think it's available freely in Pallium India website. I guess you can download. There are also alternative routes of administration that I just want you to be aware of. Apart from ordinary tablets, you have dispersible tablets for pain medication. Like NSAID comes in dispersible tablets, and also liquids or as a sprinkle, as a spray. And there are sublingual tablets available. What is the drug? I forgot. Even oral morphine, we can use it as, you can crush it and use it sublingual. And suppositories, pain medications such as codeine were available as suppositories, but I'm not sure whether it's available now. Transdermal patch, example fentanyl, and injections. So these are all alternative routes of administration of pain medication. So when you have assessed and you have treated pain, remember to follow up. So when you follow up, certain things need to remember is evaluate periodically, what is the cause. If there is a new pain, you need to look at the cause of pain and try to diagnose the pain. So this acronym is EMMA. So evaluate, explain, manage, monitor, and assessment. So explain the cause of treatment and side effects to the patient and family. Manage, careful titration, and also management of side effects of the treatment. And monitor for new pain, progressive pain, and side effects. Assessment. So you have to keep reassess both pain, relief, and also the side effect, so that we can provide a comprehensive treatment to the patient as well as to the family. Always remember, side effects needs to be given thorough attention, especially if you have given strong opiates. So expect side effects to occur and be prepared, and explain to the patient and family well in advance. For example, you write morphine, they may have constipation. You need to explain, and also how you are going to treat also is very important. So anticipatory treatment, as I said, laxative for constipation, and adjust the dose depending on the pain relief or depending on the side effect, and review whether the side effect is subsided or is it getting worse. Then you need to think of changing the pain medication. So these are all the principles of pain that you need to remember. So monitoring and also monitor for side effects. So these are the reference if you want to refer further about pain management. Thank you.
Thank you, Dr. Barathi. You've given an elaborate information, and because that is what is needed to start off. And as I mentioned, we are going to have few sessions, and just a couple of things which I wanted to add on was review. What you said is so important. We say you have to regularly review. Okay, one is to know whether what you're prescribed, is that working. Next, if sometimes it may not work, nothing wrong if it doesn't work, because then so that you go back and reassess. And ultimately pain relief is what we want. So either what you have done helps, well and good. If not, reassess, review, and then start from the beginning, and then ultimately you will get the benefit. So, and through you're going to have 3 more sessions on pain, and this methodical guideline method, if you use, that will be the best way forward, because I'm just going to use that to answer many of your chat questions. Okay. See, for example, Dr. Sri, I think, asked about this patient had lung metastasis, giving fentanyl, oxygen, all that what you mentioned. If you follow the step ladder approach, see, you will have 1 session on opioids, 2 sessions you will have one on how you will use the step ladder, and then in detail about all medications. And then you will have another session on opioids. And then like that, see, as Dr. Bharti mentioned, always morphine is gold standard. Try with morphine and then go. I don't want to steal the charm of all the sessions you're going to have. So you will have in detail cost effectiveness, medical effectiveness, everything. So you'll have 2 sessions on opioids and 1 session on methadone, in which opioid rotation, everything will be done. So those queries and things will be taken care of there. Buprenorphine, alternative to tramadol, even there are more medications available in India itself, similar to tramadol, which you can use. And then for somebody has mentioned buprenorphine is considered mild to moderate pain, but it causes extensive nausea, vomiting. Also has, see, buprenorphine cost also you have to see availability. And so all these will be dealt in detail in your opioid sessions. Okay. And then for Dr. Sanu, in Tamil Nadu, where have you moved to? E-Road. Okay. That's near Coimbatore, right? Yes. So in that case, I am basically from Tamil Nadu. I'm from Chennai. So in Coimbatore, there are places. In Coimbatore, there are 2-3 centers which have morphine. I will ask Sri Priya to send you the contacts for Coimbatore. So because I just thought if it is Chennai, I know. If it is Coimbatore, we will ask Sri Priya to send. So that is why I just wanted to know the location. Okay, anything else, anybody else? As far as I've seen the chat, I've gone through the, anyone not satisfied with any of my explanation, please unmute and speak or ask. And Dr. Bharati, anything else more you want to add on, please do. Dr. Bharati is there, isn't it?
Oh, yes. Yeah.
Yes.
Yeah. Yes. Yeah, I think what you have talked about buprenorphine is true, and I think they'll be learning more in the session. That's why I didn't cover all these things in the management, because this is just an overview.
Yes,
we want
exactly.
you to tell how pain is approached. It's just an approach to pain. You will be learning in detail about this in the forthcoming classes. So I think that will. So we
And just
wait. Unless it's
to
an
add on-
emergency, you wait for the class. Because you will be learning much more in detail about each drug and the mechanism and side effects and everything. Yeah. And for Sanup, there's Kupaswamy Naidu Hospital has got opioids. So you can, from the website, you can find out the contact details and you can call up and ask them. I'm sure they got opioids, morphine.
So now it is available. And
Yeah.
for Dr. Kavita, who did the presentation, emergencies, we have one session for emergencies and palliative care. And regarding morphine, fentanyl and all, in detail, it will be dealt. So that will help you. And as Dr. Bharati mentioned, oral preparation, if it's available, because we have to see what gives best, and then availability. If they can get something which works well and convenient to the patient and family is what we will look for. So I think Kavita's queries of all three queries also will be dealt as we go through the session. She will find answers for all the main concerns which she had raised in that slide. If there are no more queries, I will hand it over to Sri Priya. Okay, Sanup has mentioned these are far. Is there government set up to provide morphine? That much government set up to provide morphine in Coimbatore? See, that belt, Coimbatore, Madurai and all, we have to find out, doctor, if there's any. As far as I know, I am not aware of any government set up to provide morphine in Coimbatore. As Dr. Bharati mentioned, the places I knew are also private ones only. What you're seeing in Kerala, no, or what you have seen, to find that in other parts of India, all of us have to put a big effort. What Dr. Rajagopalan has done is something admirable, adorable. I can keep on telling about that, as I worked in Tamil Nadu for 5 years.
Exactly.
So all of you have to see to believe. So we can all work together to get there.
And that is why we have been running these training programs, so that doctors like you, Dr. Sanup, can get certified, can get the RMI license, and then you can procure morphine yourself and provide pain relief to people around you. That is the core vision of all these training programs. So we do hope that you get certified at the earliest, and then you get registered yourself as a registered medical practice institution, RMI, and then you can procure morphine yourself.
That also you will have a session on how to get
Correct.
morphine. So everything, this is an A to Z palliative care, I would say.
Till that time, I will definitely connect you with our facilitator for the South region, Mr.
South,
Levit.
exactly. Thank you, Shripriya. That will be better if you could link South coordinator with Dr. Sanup, and they can help him to find out the nearby places.
Sure, I will definitely do that, because we can't keep the patients waiting who need morphine. We cannot wait for our course to be over. So I will definitely connect Dr. Sanup with Lilith tomorrow itself. So with that, Dr. Bharati, we do realize that you might have had a very busy day, middle of the week, and till you found out time to interact with us, interact with our participants. Thank you so much for that. And we do really hope that we have more sessions, such informative and interactive sessions with you in future as well, because bringing in that case presentation in between was really, really interactive. So thank you for that. Thank you everyone for joining in, and with the promise that we'll be coming in again with more interactive sessions and more eminent faculties joining in. This is Shripriya, along with Dr. Bharati and Dr. Radha Venkateshan, signing off from the TIPSICO Hub. See you in the next session. Till then, everyone, take care. Bye-bye.
Thank you. Thank you to
very
Dr.
much.
Bharati, and thank you one and all.